What if everything you thought of health and wellness suddenly changed due to a hidden breathing problem that you were unaware of that affects every system in your body? Improper breathing habits are often overlooked in medicine. I'm Dr. Jenny from the Hobson Institute, and this is the Breathing Lab. Welcome, everyone. Thank you so much for your attendance today. I have the pleasure of the second interview with Dr. Duane Grummons. I'm going to just read a little bit about Dr. Duane. Thank you so much, Duane. Should I call you Duane or Dr.
You
Grummons?
bet. Thank you, everybody. Thanks, Jenny.
Yes, yes. So he's got a very long bio, but I'm going to keep it brief. Um,
Please. Yep.
so he is an orthodontist that I met many years ago at the Rockabato conference back in 2013. And our paths have crossed because he's in the same, basically, TMD and airway field that I am in. So we have a lot in common. I'm the
Yeah, for
physical
sure.
therapist part, he's the dental part, he's orthodontist that really gets it, gets airway, gets TMD. So we got a lot to learn from Dr. Duane.
Thank you.
Uh, so he's a board orthodontist. He's lectured in before most American orthodontic organizations. So, and he's got a lot of publications. He's internationally recognized for his airway-focused symptomatic facial, orthopedic, and facial forward orthodontic approaches. He has also a lot of TMD management care and non-extraction orthodontics treatments and he likes to collaborate with a lot of doctors. He just was collaborating with Mariano Roccabato last week. I was
Yeah,
jealous that you got to be with him
that was
on a Zoom
fabulous. Yeah.
call. So we have a lot to learn from Dr. Duane. And he is one of the kindest, most gentle men that wants to share his knowledge. And I am so grateful because he is such an easy person to learn from, right? He's easygoing, doesn't make it stressful. So let's welcome Dr. Duane, this platform for you to share your knowledge around TMD. TMD, it's like my baby too. I've been dealing with TMD, my world of my professional career has all been TMD until 2013 is when I started learning about airway and breathing and how it interlinked. So
Mm.
I'm going to be interjecting some questions every once in a while when I don't quite understand something. I want you to share with me what you're presenting, how it lands on me as a PT that's been doing TMD for a long time. So I'm
Here
really
comes the
grateful for
hard
this
questions. I can
opportunity.
tell. Here they come.
And they're going to come. They're going to come. And everybody, I have some news for you. This is going to be part one of two for TMD. Dr. Duane and I were talking yesterday, and he has so much to share, and we don't want it to be that long of a podcast. So we wanted to break it up into two. So you will soon learn when the next one is. So right now it'll probably be in January, but we're
Mm.
going to do part one right now. So let me just share real quick a slide on. I just wanted to show everybody. This is Dr. Duane, and if I could share real quick a couple pictures that we met. This was back in
Oh, yeah.
yes, you
Oh,
remember
that was
that?
awesome.
AAPMD, I believe this might have been, do you remember which one this was?
That was Nashville.
Nashville.
Yeah.
Nashville. And here you are with a couple other PTs.
Oh,
Greg
geez.
Johnson. This is also Nicole's husband. I'm forgetting his name. He's
Gail.
also very much involved.
Yeah,
Nicole,
Gail.
you did many podcasts with her too.
Yes.
Barb, yes. And these
Nicole
are
is
older
brilliant.
pictures. This is him and Michael Gelb. And
Barry.
also, yep, Barry, Raphael.
Yes.
And I love this picture. Look how young you both are here. I
Yeah,
don't
he was in
remember where
Marina
you
Del
said
Rey
this
with
one was
me.
from.
Oh, that was fabulous. Stayed at the house. We had the best week.
Yes. So you've been friends with Mariano for how many years would you say? Oop,
Ooh, 30, 35, maybe
35.
40.
That's amazing.
That's
Um,
Italy. We were Italy there.
Italy. So these international just collaborators, I think it's just so great. Um, Oh, and I just wanted to mention anybody that's present here on the call right now, it's just please understand that I am, oh, does it look like I'm presenting it looks like it's not shoot, hold on. Why is it not? Do you see a whole screen or is it just a little screen?
It's your slide bank.
Yeah, but you see a
Uh,
lot of different things. Why is it doing, okay, right there. And play from this current slide. There you go. So this image is if you want information about my Intro to Airway course, I'm teaching throughout the states namely in Chicago, but DC and LA. This is a course that I've designed to really educate people around airway. And if you have friends that want to get into airway, this is really the PT approach to stabilizing the airway. Um, and this is just more information about it. I'm also teaching a headache Rockabato course. This course is going to be in Chicago, March 6th and 7th. It's 21 CE credits for dentists, PTs, and chiros. It's going to be one day online for online lectures, and then the rest of the time is all lab in person in Chicago. And that's it. Okay. I just wanted to share that with you, and take it away, Duane. It's your
that
time
was
to
some great
shine.
memories. Thanks for those pictures. Wow.
Yes.
So here we go. Let's see here. We're going to share, and we should be good right in a moment
Yes.
here,
You're
Jenny.
good now.
Am I good now?
Yep.
All right. Well, again, thank you, everybody. And thank you, Jenny. Oh, for all the teaching you're doing and the benefits. Wow, I learned so much from you and everybody. We learn from each other. And so thank you, learners, for being with us tonight. We're going to do this part A and part B. So first of all, we have to distinguish when the patient is presenting, or even when the colleague is calling first about a patient, extracapsular arthrogenous problems from the musculoskeletal, the extracapsular problems, the myogenous problems, and even beyond that, all the other categories of problems that can present or be adding to the mystery and the mystification of differentially diagnosing these, because you've got the intracranial things, the other secondary type of problems, just that have to be separated out, the systemic problems. There's a lot more, but the common things you and I will deal with are the extracapsular that are arthrogenous and myogenous, and usually a combination of both. So when the patient presents, we have to palpate, we have to ask, and then we have to be listening. Just like the physician 100 years ago, we have to listen because we don't have imaging and all the testing then that we have now. So listening is huge, and they'll give us the diagnosis, or they'll give us enough essentials to make the differentials. And then we want to listen to the joints and listen to the other findings. And then range of motion is important, and then the movement, passively and dynamically provoking, adding load, not, depending on the circumstance. So we want to bring forth findings if they're not there with just usual movement and examination. So that's part of how I approach the initial patient. Then terminology wise, so we're kind of thinking the same. Certainly there's multifactorial etiology, multifaceted approaches, multidisciplinary is thrown around, but multidisciplinary suggests it's done in one facility. So you would have many modalities, maybe people together in that one place of therapeutics, and it's multidisciplines being applied, or you doing it in your house. But it's really more accurate to say it's interdisciplinary because we're sending them out, we're working together in a team, collaborative way, and we're integrating our care. So we're bringing in all the different things we know, and we're all pieces of the puzzle for the sake of the patient's wellness. So in the orthodontic arena, the American Association of Orthodontists has created a rather good intake history. So there's one there if you want to search that or get it online. It's easy. It's pretty well done. Then what we do is we have a history that I prefer. I put this together back when I was still on UCLA faculty. This would have been in the 80s. I've modified it, of course, added the airway and other things that we do today. But what I like about this simple history, four-part, is the first part has to do with jaw function. So it's musculoskeletal, it's just general function, part A. Part B is intracapsular. The top right is chronic pain circumstances and findings, because that it presents different and is reported differently by the patient. And then the fourth category has to do with systemic. Simple questions, enough to screen, enough to bring forth findings to let me go deeper into what applies to them or is pertinent. And then the references are good ones. These are four of the better in orthodontic arenas. So this was done back when we had McNamara's references. And looking down the line, you can see Chuck McNeil, my book, and then or our book, because others contributed, and then of course Jeff Okeson, who's the master of all of this. So those references were used, and I'll explain a little later in what ways. But with this history, I can flush out in category one some of the musculoskeletal problems. Category two, the clicking, the joint functional conditions. Top right three, chronic pain and other long-lasting, more problematic things for patients. And then category four, systemic, which was none for this patient. A lot of colleagues will just take a pan-oral and rely on that. And certainly we can get some information, and that's been useful over the years. But now with cone beam and 3D, which we've been using since '02, so that's 23 years already. And in office, we've had it since '08. So that's a long time to rely on cone beam. And we've gone through the moving the mountains and climbing the mountain and taking the challenges with that, because initially everybody thought it was too much radiation until we could get them to understand it's the opposite, and to understand we can choose fields of view when we do our imaging, so we can even be more aware of the ALARA principles and protect the patient in the right ways. So one of the first things I do is I ask them to show me the headache. And I have a MA next to me, or a dental assistant next to me with a camera and capable of recording video, audio, or both. But as I'm finding things, it's real easy to record just by taking some pictures or a 3-second video. And it's so much more helpful for me to refer back than any chart notes I can make. So we chart, of course, but we have the imaging person present, and we have people cross-trained. So a lot of people can take these images for me. But when things are being reported and revealed, then we're capturing that in pictures and with text. So top right, musculoskeletal, obviously. Then we're checking the intercapsular, the jaw's moving. You notice my right hand is on the border of the mandible, because when we open and close easy, it might not be a problem, but yet with a little lateral pressure, it's enough to make the jaw displace laterally, which puts the disc medial laterally, and all of a sudden a click appears that wasn't there. So just a little functional loading, easy open, easy close, because I don't know the degree of problem yet. I don't want to hurt the patient. I just want to go easy. And if there's problems or discomfort, then I'll back off with these things. But these are initial things so I can record and discover and bring forth things that are going on for the patient. These are recordings in 4 different fields here. One is speech, one is aesthetic. So I have them smiling and swallowing, doing things. We'll rotate the head. And then the lower right field is the one where it's functional exam of the TMJ. I'm talking, so that as it's recording, the audio, things I'm finding, observing are being said. If the patient has something to offer, that's being said. So it gets in the recording. And then let's just look at this, a few pictures of showing me the headache. So doesn't your mind start to go immediately to what might be going on? And notice if the hands are open, it's very different than if the hands are pointing. So we're looking at musculoskeletal, and we're looking, is it 2 sides or 1 side? Is it pointing? Is it open hand? Because that tells me something about the site and the source for the problem. So the upper left screen, obviously very localized, and you're wondering, is that neurologic, intracranial? What could it be in the area for the patient? The other one deep behind the eyes, is this sinus? Is it intracranial? Is it musculoskeletal? Secondary referral to that region? But the hands are cluing me being open and bilateral versus one finger unilateral. So it's a clue. Then here's the patient trying to report to me what they sense, what they feel, experience. And you see bilateral. You see, is it sinus? Is it above the eye, supracrestal? The other 2 fingers, bilateral, probably ascending referral, myogenic or musculoskeletal, craniocervical or cervicogenic type of secondary referral. And then across the front, both sides, open hand, head leaning forward many times. So is that intracranial? Is that sinus? Is something visual? What field is that? These are clearly musculoskeletal. So it's so diagnostic. The hands to the face, the side of the face, retroorbital, all these things that are maybe a combination of facial muscles, masticatorial muscles, and certainly craniocervical groups in the upper quarter. So we're right away knowing we're going to find things in the upper quarter. Here's the patient again, hands are open, both sides, telling me where it's coming from. It's back here, and then it ascends up and over behind the eyes, to the side of the face, to the temple, and, it's a vertex. All these things are cluing me the origin. And obviously, I'm going to be thinking right away of referring to you because I need my colleague more than me for at the beginning. And we tell them that. The physical therapists, the OT and PT are going to benefit you much more than anything I can do. But put us together, and the four that they bring and the one that I bring, that's five things that are going to get better by our combined therapy. So again, these pictures I share with the therapist. And another thing with the sleep categories, we know that many of these tension headaches are tied to sleep patterns and fragmented sleep and other findings in the sleep studies and the sleep reporting. So we're not saying it's this yet, but we're starting to think what else could be contributing to this. And sleep pattern is understood. Well, we're going to get going with craniocervical. That's more important than things I'm going to do, although we are going to team together. So the original Travell charts we bring out for the patient, these have been around my whole practice time, and they've been useful the whole time to help patients connect the site and the source for these problems. And so we bring these out, we have these printed, we mark on them so they can see what they're reporting and how it ties to where the headache is experienced. I'll test the jaw, I'll actually ask permission. Can I palpate neck and shoulder areas? Because I'm an orthodontist. And they're going, what's he doing touching my neck? So I want to always ask permission and explain why and show them these connections. And then, of course, they're typically going to say, of course, help me all you can. I've been suffering with these so X number of months or years. I've been involved with this most of my career. I mean, early on, I started learning from colleagues, and Mariano, of course, was one of the first. But Stephen Krauss, way back before,
Yeah.
I met him early on. I did a chapter in his book, so this is early '80s already that we're writing this, and Mariano and I are meeting about the same time, and just going around and speaking to meetings and learning from each other. But it was certainly a time where we had trouble having colleagues become engaged and really interested in this. There was a lot of pushback and push away. They didn't want to do that. They'd say, I don't treat TMJ. And to me, it would be like telling a dentist, I don't treat patients with periodontal problems. I don't treat patients that are missing some teeth or, I mean, it's just part of what we need to be aware of, but capable to manage or send to a colleague who is. So I want to thank Mariano over and over for all these taught me, all the books, the times I've sat through his courses, even his back courses, other things, because I learned so much. And it helped me. And then now with our imaging, we can also look through and scroll through on the axial, the coronal views especially, and look into the cervical complex, share images, look for side bend and other areas that are not properly aligned or functional, and share those with a colleague or share the whole data file with Jenny, Dr. Jenny, or any of you or anybody who asks. So we ask permission and then we share the data. Why not? It's for everybody to benefit from. And then as part of the exam and even part of the therapy, we'll add resistance once we've identified the problems. And one of the things at the exam, if I put my hand or palm on the front, on the chin and push forward and activate the lateral pterygoid muscles and the superior head especially, they're going to go, oh, that's so uncomfortable. They won't say painful, but uncomfortable. They might grimace. They might reach to that area. But it actually helps me confirm that that's part of the problem or part of the origin. And then during therapy, we're going to use a hand with light pressure to gradually open with loading and just kind of strengthen and rebalance muscles. So there's several times where I'll use this. And then another thing I mentioned already is using my palm gently on the side of the jaw as they open and close actually is going to either help reduce the disc that's medial. So if you're on the same side and you gently encourage the jaw medially, it's going to put the condyle under the disc and help them move together. They might have an opening click with lateral load or lateral pressure, lateral assistance, really. If I assist as they open, it puts the condyle medial and it loads it medial, and all of a sudden the disc doesn't click. And they're amazed. So they open, and there's a reduction click when they open. There's a reciprocal click when they close. I put lateral pressure, real not heavy, but enough that I can make a difference. And all of a sudden that assisted support reduces the disc and holds it in place. And the collateral ligaments may not be capable of doing that. And so they're surprised. And I say that's only to help you understand the importance of coordinating the condyle disc assembly in functional movements. So we might need a little assistance to guide that, or muscle therapies, uh, relocate the condylar positioning for different loading. So that begins to lay the groundwork for what can we do with our therapeutics in conjunction with what you do for all the therapeutics. So looking at a drawing of this, the lower right shows the disc is actually medial and anteromedial displaced, so lateral pressure, and puts the condyle under the disc. It'd be like we tell patients it's like the saddle should be on the horse, and wherever the horse goes, the saddle goes with it. When the collateral ligaments have laxity or there's displacement, either partial or fully, then that saddle gets off to the side of the horse, and we have to bring the horse under the saddle to reduce it. And we'll do that with therapeutics, and we'll do that just by demonstration with loading or assisted support as the jaw moves. So we're using it to be provocation testing to reveal problems, but also assist to show that there can be a coordination there and an improvement in function just by things we're going to do together. So it helps them understand and not to have them buy in, because we never want that. We want to make them thirsty for the information, thirsty for the treatment, and then accept that. It's never us convincing them. We want to give them all the information we can and let them have an informed decision and then proceed. So we're going to do the palpation of muscles and all that. We're going to listen to the joint, because there's things we can feel and not hear. There's things we can hear and not feel. So we need to do both. So I have a stethoscope, of course, and I use an amplifying one. So there's a battery in it. So it's amplified, it's sound assist. I can change the volume and the quality of sound for different crepitus. But I like this as a stethoscope because I can hear much better and distinguish categories of the sound. So they open and close passively, and I might ask them to open with resistance, of course, go laterally, but I want to do this cautiously because I don't yet know the degree of problem or discomfort. And if they have greater problems, more chronic problems, I don't want to get into a lock in the moment of me doing an exam. So I want to be careful and gentle and yet reveal the problems. So in opening, you can see the diagram, which Sam Higdon is a retired TMJ dentist in Portland, but he did these drawings. He's an artist and an accomplished one, but he did these drawings and improved them years and years ago as we learned information and as we learned the two heads of the lateral pterygoid and differential function of those. And now with cone beam, it's even better depicted. But as we start opening, there's that place where we reduce the disc, or at least partially reduce it. The sound changes. We might accomplish the full range of motion or maybe not, depending on the conditions. And I want to give you this reference of drawbridgegds.com. It's Jim Howard is a colleague here in Spokane. Jim and I have done some real complex cases together. He ran the Seattle pain clinic, facial pain clinic, then came over here the same year I did. So he relocated here, and I moved up from Reina Del Rey with our family, and we've been here together almost 30 years. So just it was a wonderful fit, and I couldn't wait to work with Jim. And so this is the partner of Sam Higdon in this whole effort at Drawbridge. So they put those drawings together. Range of motion, of course, we're going to measure opening. So it's active opening, no stretch yet, but they open to their comfortable range, we measure, and then side to side, we measure. And one of the easier ways to kind of have the patient go naturally side to side is to put a bite stick between. So I first mark the bite stick in the middle. I line that up with the upper midline, wherever the teeth are. I place that and hold it, and then have them move the jaw to one side, and my assistant marks where the lower midline goes. Move to the opposite side and mark. Take the stick out and put a millimeter ruler next to it. And you've got the lateral movements, and you don't have the teeth interfering or having the patient try to follow what you're instructing them to do. You simply bite lightly and slide to the side, slide to the other side, and then open comfortably wide. So comfortably wide. So that's this measurement, comfortably wide, and then side to side. The instruction I've learned to give is say glide to the side. I don't say move to your left, and they're thinking which way is left. Glide to the side, and they'll always go to their dominant side. It's so interesting. If they're right-handed, they'll go to the right, and then say, okay, move to the other side, glide to the other side. And they follow that instruction, and in a few seconds, you've got your measurements. So that just, I think it's more accurate, comfortable, and teeth are separated this way. Okay, one of the things that affects side to side, not often, but we'll see it on our imaging, is an elongated coronate process. Because when they go laterally, if that coronate is well developed and long, it's going to ride up into the posterior maxillary complex, that whole region, and they'll go to the side and they'll actually bump the anatomy, and they can't accomplish full side movement. And yet when they're open, they can go freely side to side, and it's a little bit confusing. And it's that long coronate. So on the panorex below, you can see the long coronate on that right side of the screen, and it's elongated. When we get cone beam, of course, we can rotate the volume and look exactly at this and capture that region and then take a screenshot. So it's very interesting. It doesn't come up much. About twice a year, I'll run into it. Okay, and then they open comfortably wide, and this patient's limited at 2 fingers. We generally would say 3 fingers of the non-dominant hand is a good range. So somebody's at 2. So I don't know if that's a muscle limitation. It probably is. But if I've already measured side to side, and one side they move 7 or 8 or 9, the other side only 5 or 6, I know there's some reason the other side's not translating. So when they open, they should be limited, but they should deviate to the affected side, as opposed to just opening symmetric, which is probably muscular. So I have a clue just by when I measured what they can do side to side, and it prepares me for when they open what I should expect, and if it deviates or doesn't. 3 fingers is normal. This helps me get end feel. It helps me just gentle stretch, or use 2 fingers to gradually scissor and see if it stretches open so the muscle releases a little bit. But it gives me a clue about that. I never want to hurt them. So I always tell them, you do it easy with your fingers, or I'll do it easy. But it helps me accomplish the movement for that day. And then if the patient's moving well enough, and we're not off the disc or uncomfortable, a lot of inflammation, I won't do this. But if I can, I'm going to grip the whole mandible, my hand in the mouth, thumb on the back teeth, and I'm just going to stretch the whole capsule and just get an idea about that. And I'm going to go to the range of opening and just easy stretch and see if they stretch typically 2 millimeters or maybe 3 beyond what was the usual comfortable opening. So the end feel reflects the resilience and it reflects health of the joint. It should be able to do that. And so end feel is important to me. Thank you, Mariano, for teaching me about that. And then from the angle from the side, you're gonna right away notice if they're a low angle, like the lower right side, a real square jaw, versus the top center where you see it's kind of a tapered jaw. So we start thinking in 3 facial types: the square jaw, the brachyface, the more tapered is mesial face, and then the highly tapered is dolichofacial. And the range of motions are different in each of these facial types, and the shape of the condyles are different in the facial types. The square jaw is built for function: big wide condyles, big thick disc, and big joint space. It's built for function. And so muscles are big, cross-sectional area of muscles is big. So we need good disc and big anatomy to support the heavy musculature that goes with that big brachy face. The tapered, long, thin face might have only 10 or 20% of the cross-sectional area of the elevator muscles of the mandible, like the internal pterygoid, for example, much less mass to that muscle in a long tapered dolichal face. And then the condyle shape itself, the eminence shape, is going to reflect the facial type. And that's because the function of the muscles, the load of the muscles, has shaped those parts. And then during the growing years, the parts have developed in response to the function. So that's the anatomy we see on the images in real life on the patient. So I want to take into account the different facial types. So the research I did is published in the late 80s already, but I took 500 patients in each of the 3 facial types, and we measured the range of opening. So that when we measure, if we're thinking, well, 3 fingers is typical, 47 millimeters might be more or less an average opening. However, in the brachyface, it's about 5 millimeters more range of opening. And the dolichal face is 5 millimeters less. So if I'm measuring 42, I don't know if that's reasonably normal or within range for that face or not. 42 for a brachyface would be 10 millimeters less than it typically should be. And that would make me question, is there some muscle limitation, some shortening, that foreshortening that's not letting them go to range? Is there some problem with a chronic disc dislocator? So anyway, to make the point, they open differently. So the left vertical box, there's 5 millimeters difference of opening on when we measure the three facial types, and that's normal for each. Laterally, they're different by about 2 in each of the facial types. So 8 to 10 might be the average width, but 6 or 7 might be the lateral movement for a dolichal face. That's all they go. But a big structural brachial face will go out 10 to 15. They're hypermobile. They go too far. So we have to caution them and teach them about not biting with the mouth too far open or off too far to the side, which loads the whole joint complex inappropriately. And then protrusive is different also by a couple of millimeters in each category. So I think it's real important to look a little bit at the face, kind of the angle of the mandible, what's the face like? Is it square or tapered? And then what might be the range for that? And when we do dynamic, using MRIs and four-dimensional stuff, we can have some beautiful imaging. We can see the opening where they close, where they open. And it's pretty and it's revealing and we like it. It's very visual, so patients learn quick. But there's more to know. When the patients open, as they open and they get pretty much the full range down the slope of the eminence, the condyle keeps on moving, but the disc really doesn't. And so it kind of counter rotates on itself. So it's like, I tell patients, it's like a hat on the head. And when you get way open and you're moving, it's like you're tipping the hat back. The condyle is going further, but the disc is being just limited by the collateral support, the posterior attachment, and it really can't go more. So we don't want to over-translate or hyper-translate because of that rotational effect of a condyle and disc assembly. And over time, if the patient is doing that, then there's going to be a point where the disc becomes so able to freely slide around that we'll get into clicking, we'll get into sometimes a disc dislocation problem. So we know that range of opening, when it's hyperlaxity or when it's just hypertranslation, that is a little bit of a risk, and we just want to caution the patient to limit that. Because of hypermobility, when we go too far, that disc is rotating back, the hat's going back on the head, and there'll be a point where that disc starts to slip out of place when we close. The opening click is reduction, so we can open, but when we close and close with a reciprocal click, that's a problem. And that's the one that then we're going to use orthotics and other things to change where the relationship is on closing, because we can. The opening part, we're going to limit by teaching the patient and by what you teach them as far as their proper ranges, and then getting the musculature balanced. And of course, there's hyperlaxity as another condition. There's this collagen problem and this collateral ligament problem. So we take these pictures, and it's right out of the textbook, some of the examples, and we'll take pictures and we'll ask them, the elbow, the fingers, and that sort of thing, and capture 2, 3 pictures to tie that to what we might see with mandibular mobility. And then part of the instruction is with the who are chronic dislocators, will operate within 80% of their range of motion. And so the tongue goes to the palate, they hold it tip on the incisive papilla, tongue stays there, and they open whatever they can without the tongue coming off. And that's their new range of motion. So they learn that, they develop awareness, and they open about 80%. So we don't click on opening, we don't click on closing. And we're not trying to stretch out the collateral support on these kind of patients. So that's simple instruction, and it's up to them then to be aware of that. And we tell them, when you're sitting at a stoplight or just any time that you're idle, put the tongue up there and practice 5 times what your new range of opening is. And they do that. And so these hyperlax type of patients or hypermobile patients need some instruction on what they can do as self-help as part of the therapy. So they learn to limit that range of opening, and then that assists us in kind of resolving the problems that might present. Okay, and this is a MRI of movement, and you can see the relationship of the condyle and disc, how well it holds. I'll back up and play it again. And you can see the disc, and you see the condyle under it, and you see it going to a good normal range, a little bit beyond the eminence. And we try to teach that soft tissue disease precedes the hard tissue problem. So on imaging, we're going to see changes in the contours on the synovial region, the functional regions, on the eminence and the condyle. But the soft tissue had to break down first to allow those synovial regions to start modifying and remodeling and changing enough that we see the hard tissue change on our imaging. So the soft tissue stage is where we want to get the inflammation managed, get the functional loading managed, and get conditions optimized so that we prevent them from going in a cascade into further problems. These two MRs are, this has been from probably 30 years ago already. Paul Berger was a radiologist in Torrance, California, moved to Coeur d'Alene, Idaho, but his imaging was the first of MRI without contrast. And we were still doing arthrography then. And immediately this changed everything we did. But these are beautiful images from way back then, and they're better now. But it shows us the shape change in the disc when they're out of place. But also it shows us that superior to the condyle, it's not condyle directly on bone. It's not bone on bone. There's a tissue in between that's gradually repaired and remodeled. And that tissue is fibrodisc. So it's posterior attachment that has been stretched up and over time, and it's modified. It's basically tissue cells that are undifferentiated mesenchymal cells, which are like stem cells, capable of modifying and becoming fibrocartilage. So the images show us the disc is way out, but the patient still has a functional load-bearing area. It's not inflammatory. It's a functional load.
Dwayne, can you show us right there where that disc is? I think the arrow is showing us, but can you move your cursor right where the
I'm
disc
moving
is?
my cursor, but I don't think you're seeing it on screen, are you?
You might be.
I
Try
don't
to
see
move it
it.
around. Nope,
Yeah.
it doesn't.
The dark,
The
like
dark part in
top
front of the
right.
condyle in the picture on the left.
On the left, you see how the whole disc is such a misshapen area. It's thick,
Yep.
halfway down the slope of the eminence, and then it's real thin, which would have been the central area of the disc. And then the foot of the disc is kind of that kidney bean shape way down low in
Yeah.
the image, but that's all
Okay.
the disc. And in
Okay.
this case, it's very thin. The black around the condyles, that whole cortical region, and the right side image, we have a thicker zone between the eminence and the condylar slope itself. We've got better shape, but still both condyles are really pretty good shape because this is adapted over time. And so our focus might be, oh, the disc is displaced. Yeah, but nature has wonderfully done a remodeling and repair and favorable regeneration of the attachment zone to give us a fibrodisc. So we actually like this. And on our next session, when we go into more advanced intercapsular problems, this is actually one of our therapeutic goals because
So
we
you're saying here, this is the pseudodisc, right? The posterior
pseudodisc,
ligament
exactly.
becomes a pseudodisc when
Yeah,
it's out
pseudodisc.
for a long period of
If the
time.
posterior attachment stretches over, if it's
Yep.
inflammatory, it hurts and the patient presents. But this has happened naturally. By the time they come in, there's limited opening. There's really not a capsulitis. And we take images and we go, oh my gosh, look at this. Except there isn't a substitute disc, a pseudodisc, a
Right.
fiber.
Got it.
So we go to imaging. And so on youth, there should be much more joint space. The condyle is not seated like it is on adults. There's a thicker disc area. It's highly vascular. They're growing. The condyle should be, if anything, a little bit more forward because all this vascular growth area is underway. We don't see it on the image because it's soft tissue, but it's what precedes the eventual growth. So that area is thick. There's joint space, and that's a normal image. And then the images, if an office is newer or a case is more complex, let's turn to our maxillofacial radiologist colleague. Let's turn to them and get a radiology report. They'll give us much more information, they'll detail it, and this becomes a tutorial because we can sit down with these images and find them in our own data file and look through and learn from this. And of course, it's better than what we might see, especially if we're newer. And it also reminds us to make a radiology report to our file to prove that we've looked at the images and what have we observed. We can do a simple RAD report and then file it to the patient, which confirms the findings, but it gives us a quick reference when we come back to that patient at subsequent visits. And medical legally, it's really important. So, the colleagues that read these for us are fabulous, and it becomes a great tutorial to teach us things. And when we language this with our colleagues and with each other, we don't call it an X-ray for sure. X-ray is out of the vocabulary. So we just teach officers don't even use that word with patients. So you're doing digital imaging, but even when we take an X-ray, this is capture or acquire a data set. So in the IT world, we're acquiring data when we take this, and we're basically looking at the radio opacity or radiolucency, but we don't use that word. It's really attenuation, high attenuation, low attenuation, and capturing data. So different words, and pretty soon everybody in the staff starts saying the same thing because we're learning this together and teaching it. But then the patient hears a different language to know it's not just about radiation, taking x-rays, and oh, I'm fearful. No, this is new stuff. And it sets you apart, differentiates you from another office, maybe. Looking back, say 10 years ago, we were having to write quite a few articles in journals to kind of deal with the controversy and the pushback. And of course, now, it's well accepted, cone beam. But when we were first doing this 10 and 15 and 20 years ago, we were fighting a battle and taking a lot of incoming. So it's the same thing with airway now, where we're still climbing that mountain, and we're not moving the mountains, we're moving pebbles. Trying to make a difference here, but we're climbing and we're having an impact. But I found myself being asked to put articles out, so we did put a lot out with the images and how it benefits patients, benefits care, and what the orthodontists should be doing when patients come in these days. So they're there. If you want them, I'll share them. Most of them are posted. What about arthritis and arthrosis? Important distinction, because the arthritis suggests inflammation now. Arthrosis, there was previous inflammation that has subsided and has gone through remodeling, and now it's non-inflammatory. So we want an arthritic condition to become an arthrotic condition on the joint surfaces and within the whole capsular region and intracapsular area. So when we see remodeling change, it doesn't mean the joint hurts. Well, the soft tissues hurt. The joints really aren't what hurts, the capsule and the soft tissues in all these areas. And gradually there's change in loading, there's change in morphology. Parts start to look different, but both sides of the joint are changing, the condylar side and the eminentia. So we're looking at both sides with our imaging and then scrolling through, capturing screen prints and understanding, what has happened versus what's active right now, and then how we team up as therapists to help that patient for the problem. And basically, we're taking conditions that might be intolerable, painful, uncomfortable now, trying to either make them tolerable or, better yet, resolve them. We're taking maladaptive conditions and making them adaptive. We're helping the patient, the biologic organism, to readapt and to remodel and to become physiologically stable and comfortable and healthy or well. Degenerative conditions, we're encouraging repair by things we do together. They have disabilities. We're trying to rehab and take away those disabilities. So it's all these things that we're doing as a team. So I use those words and those languaging in our communications, in our correspondence, and just in our patient management. So TMJ, we get some nice images. We get a read if we need it from our colleague. And a lot of different images are taken. We look carefully at each one, make recordings, and then share them widely. When we start to see changes, and in this case, the far left fields, if you look at those 3 or 4 cuts, you notice the remodeling change, the lack of cortical contour, and just compare the R1 and 2, and then look on the L far right, 1 and 2. So the outside 2 images on one side and the outside 2 of the other. Just let your eyes see those 2 right now. And immediately you see the difference in contour, the shortening on one side because of the shape change, the remodeling. The eminence is actually flattening a little bit more. So the left side is either actively inflamed or was inflamed enough that remodeling occurred and the structure shortened. So in the face, if it's a growing patient and one side is shortening and remodeling, the face is going to start becoming asymmetric. There's a shorter side. And it can be the same in the adult, but in the growing patient, it's even more dramatic. And also what many times happens is the antegonial region will start to bend. So there'll be a notching. On the panrex, it'll show. On lateral ceph, it'll show. So right away, when I see changes, always compare the 2 sides. But when I see changes different on one side than the other, I'm not thinking that's unique to that patient. No, there's something different about the functional anatomy in that patient. I'm going back to the face and look for asymmetry, going back to my clinical exam and findings, see what else accompanies it. So I can treat that. And that's where I might use medications or phoresis, other things with your help that are going to attack the inflammatory conditions and get this under control to resolve it quickly because it's disrepair. There's degenerative changes, there's remodeling changes that are not favorable that are underway. So I want to address that quickly. Soft tissue disease precedes that hard tissue change that we're picking up on the image. And then these are, again, the examples of images. But the key thing on the growing patient, especially, is it starts to alter the facial morphology. We start getting a short side. So the occlusal plane starts to tip up on that side. The ramal length starts to shorten. The condylar length shortens. The mandible body bends from the ramal process. So the angulation changes. The midline starts to shift to the short side. So in the occlusion, there'll be a two occlusal plane different on the two sides. Midline shift is common. Mandibular body length is different when we measure it. The ramal height is different. The condylar process height and angulation is different. All those things are changing, and especially on the growing child. So it's important to us. By the time they're an adult, we've got this circumstance because that's preceded now the patient coming in to present for it. And one side degenerative, disc is out, a lot of painful limitation of movement, and obviously a lot of skeletal asymmetry. And the 3D beautifully displays that. We can use software to help us really see these things, accentuate, and help the patient see the etiology. And then if it's a surgical assist or some other more extensive procedure, they're going to understand why, greater problems require greater therapies. Now, along with all this, there's the bruxism thing. And before we would think about the condition itself, the parafunction itself, and now we understand the sleep related bruxism driving many of those patients. But certainly in worn down teeth on the very young patient, we get a second chance with permanent teeth if we've intercepted the problem. We get to where beautiful smiles can be created. But older patients that have had this for years, that we may see the lingual tori and other things come on with the patient that's bruxing aggressively in years and for many minutes and hours of a night, and then disrupting the sleep cycle too. So others have gone before to start identifying the comorbidities here and the relationship between facial pain, obstructive OSA type of problems, and then the sleep fragmentation and the other disruptive things. And many times it's the breathing problems that have preceded this. But by this time, we're seeing things in the mouth, the dentition, the anatomy, the reporting, the history. All these things are driving us toward the same etiology, and a lot of it has to do with sleep. And really, we get concerned about the breathing problem, like we talked about last time. The breathing problems precede the sleep problems. So the kids' breathing and the ventilation and all the problems with mouth breathing and other things are really important to just deal with the health and wellness of the child. So by the time they're an adult, we don't have these secondary greater problems. So we take it serious on the young kids when they're grinding their teeth, and we look to sleep and other reasons right away. A chapter I did in a periodontal text was addressing this, bring it to their attention that when they see these problems on their patients, don't just put a night guard in and cover it up because teeth are worn. Go back to get help from a colleague and seek out the etiology for it when they have worn off teeth. We look at stages of sleep and arousals and other things that are related to this. So when we have worn teeth also, there's colleagues in dentistry that will say, well, your bite's off, you've got bite interferences and all this, or when you glide to the side, the teeth don't clear. It's called cuspid guidance, or the teeth would lift and separate so the teeth on the opposite side are clearing. Of course, if teeth are short and we glide to the side, the teeth in the mouth on the opposite side may interfere or hit or connect or glide past each other. So dentists many times look at that and are quick to say, well, you need to equilibrate the bite. We need to shorten up those teeth that are colliding in lateral movements, when actually we need to build up something. It's worn down, let's build it up so it clears rather than cut it down even more. So that gets into a philosophical thing right away, because the restorative person isn't wrong. The teeth are interfering. But the remedy for it is to build up and restore the functional parts rather than taking away something. And so we look at contralateral context for sure, but we want to restore. And we always look for degenerative changes when it's getting shorter or the loading is unequal on the sides. Okay, and so there's neurologic reasons. Jerry Simmons and others have done beautiful publications connecting the sleep and the neurology of this with the hyperactivity and the wearing of teeth. So the kids come in and they're like this. All I did was ask him to give me the alphabet, and then this whole activity kicked in. So it's part of this sleep problem that we talked more about last time. But the point I'm getting to here is the bruxism that we see, and they might have muscle findings, they might have crepitus or joint findings. So you're finding these as part of a TMJ facial pain arena, but we still look at sleep and the bruxism as part of the etiology. And then we know that the patterns of muscle activity, they're phasic in some of the sleep problems, and they're tonic, where they're more aggressively, actively grinding as they partly arouse and partly awaken. And so the muscle patterns are really aggressive. So sure, they wake up with mesenteric tenderness, lateral pterygoids are real tender, temporalis, anterior temporalis, especially when we try to open with load, they report greater discomfort, protrusive, for sure, they're right away discomfort, uncomfortable. So all these things tie together. So we have to co-manage these sleep issues with anything we're doing in the TMJ, TMD, facial pain arena. So I would point you back to Jeff Okeson's writings. He is the master. He's the Bible. His books are the answer to these. Jeff has worked his whole career. One of the times I was on AAO, our national program, with Jeff, and we talked about these things, him talking about the phase one, the pain management phase, and then what do we do after that for the patients who will benefit from orthodontics or corrective procedures or orthognathic surgery and jaw procedures. So that's where we fit in, is how do we bring them to a finish with all these complicated things. So I've published things on this, so have some of these colleagues, but Jeff is one of the masters. Ricketts was the first to teach all of us a lot. Ricketts has passed away a few years ago, but certainly I credit him for driving us to learn all this. And then others in your, Rocobato and Jenny and others that are teaching and carrying the baton of knowledge. I mentioned already, we wrote this dialogue for the orthodontists because in the late 90s, 80s and 90s, there were a lot of litigation, a lot of caution. Nobody wanted to treat these patients. They were pushing away. So we wrote this, but it's 25 years ago already that this has been in the hands of the AAO as a white paper to kind of prepare the colleague and have something to help them. But when you look at our journal, this is 2020, but an example showing how our colleagues are with managing the stomatognathic or the jaw dysfunction cases. Orthodontists don't sign up for it. They don't want to do it. So this is published in the Journal Survey of Orthodontists around the world, but these are USA ones. And you see there's only 10 patients in a year that the median orthodontist was treating. And prior years, it was only 5. So they're saying no to most of these patients. And that number as a median doesn't mean all orthodontists are doing 10 cases. That's a median. So somebody's doing 100 and 9 other people are doing none. That's the problem, finding an orthodontist that does this. Okay. Then the consent has to be different too. Braces are not for pain. So that in the consent, we have a secondary consent that goes with the consent for the therapy, but braces are not for pain. And it really spells out languaging to help the patient understand if there's something chronic, degenerative, systemic, cranial, cervicogenic. That's not going to be helped by me making your bite the best I can make it for you. So we understand what things will get helped and what things actually require others to help. And if there's hypothyroid conditions or some other systemic condition, then they have to understand that's not something our orthodontic treatment is going to help for. There's lots of manuals and things many of us have written to help our colleagues understand, but we would start these people with some kind of orthotic, assuming that's appropriate for the findings. It could be upper or lower. We like a horseshoe shape so the tongue can have room to fit and functionally balanced. It can be lower. I use lower as much as upper, and there's many reasons. Easier to speak with the lower, but it's still a horseshoe. It's thin and it's generally a hard surface, so we can mimic the proprioception that you would get with teeth touching, and it has to be balanced. Glide to the side. So when they're wearing it, I'm checking everything. I'm saying the same thing, glide to the side, and they'll do that for me. Glide to the other side, and it'll do that. So I can get this balanced and properly stabilizing the mandibular complex. And then we start getting into the brackets or the Invisalign or whatever is going to be used. And we'll start to take those splints and segment them. Because by this time they've learned muscle memory, they know how to target the splint, they're comfortable with that reference position. And so we can take part of the splint away and not lose our index or our landing target for the jaw and the muscles. They might have a day splint and a night splint, especially if there's bruxism or other conditions or the off the disc some of the time. So we might have a simple, thin, small day splint and a larger night splint to help manage everything. And then we don't subscribe to some of the colleagues that will wear a splint at night and then give them a morning aligner where they bite and squeeze 5 minutes in the shower to get the jaw back together and get the teeth back together. Because what they're really doing is compressing back to their pathologic position instead of the new reference position, the therapeutic position. So if we've got a better position of comfort and stability, then we want to maintain that day and night and then bring the teeth to fit that same position, not try to bite back in the habitual position that was pathologic. So we don't squeeze and compress in the morning as a way to get back to where the teeth seem to fit. Part of the remedy then too is building up teeth temporarily in a way I can modify them easy, which means putting plastic on them, little turbos on key spots so they can land on the key spots. If you have two per side, it's like a table. They'll be stable with two reference points per side to target, and it could be the same position that the splint puts them in. So for example, the bottom screen has two little composite areas behind the upper canines. You see them kind of bluish green in the diagram. So when they bite, that keeps them from biting all the way. The problem is there's nothing in the back. So if you have healthy disc condyle complex and muscle problems, you can use that and they won't bite as hard. So the musculature will be more relaxed and they'll be fine with that as a little bite lift. So that's okay in the front. However, if there's intercapsular instability, the disc slips in and out, we have to add posterior support, just like a splint gives. So the turbos then move to the back. So we can make the teeth move, make them all pretty, but the splint covers the whole arch. And if we're using aligners or something, we need something at the back to be supportive when the whole splint is out. So we might have a nighttime splint and daytime just have the composites holding it, and we're busy moving the teeth. So if they're more chronic or more one side is unstable more than the other, then you'll see in the top center picture the little white composite that's on the back first molars. So when they close, that is part of the support region. They target that. Then at night, cover it up with a full splint to give them the full support. But during the day, that's their daytime splint. You just need a couple of contacts on the side. I can modify it as the bite's improving. I can add more, take away as the need is. If they come back and say, oh, that click is starting to come back, add a little bit back to decompress it. If I decompress it, I put the horse under the saddle so it's supported and the disc stays in place better. It helps the collateral ligament support. So in the back on the liners, we take the attachments that usually are on the side somewhere. In the software, we slide them up on top of the teeth and they're actually in the appliances. We don't put these on the teeth. We put them in the appliances so that we don't have to put them on and go through a lot of procedures and have the patient go through a lot. These are just in the appliances and we can change thicknesses as we go through the correction, but it's very simple and very helpful. And so we decompress at the back, but it's no different if it's in the appliance here with the aligners than it would be in the mouth in a situation like this. These are on the teeth, these are in the appliance. And so we decompress that way. Sometimes on the patient, that's much more of a problem where their bite is too closed, deep vertical, lack of vertical support, overclosure, things like that. We might need immediate significant support. So sometimes the top left screen, you see there's 4 large crowns, 2 premolars and 2 molars. Those are temporary crowns. We've taken a scan and they're made by labs. They're just plastic. We bond them on the teeth right over the top. We don't cut their teeth. There's no preparation, no alteration in enamel. They go right over the top. And immediately the patient is supported and they're held in their therapeutic position. Then at night, we can cover that up with another splint, or they may not need another splint. But we use these as we're going through the correction and thin them down, and eventually they go away. But those are about $40 a unit. So colleagues will say, I can't do that. That's like what dentists do, and that's $1,000 a piece. No, these are temporary provisionals, and they're made with 3D, STL files, and they're quick. They fit exactly. It's so simple and quick, and immediately it's beneficial to the patient. So we do these extra things because it helps us be successful and manage the patient and not have a lot of emergency appointments either, because it's a reliable way to help us manage these problems that are more challenging. The top right, it's bonding I put on the teeth. And then the lower left screen has that crown that's big. You see it's longer than the other teeth. Why? Because that has to be the contact area for support. And purposely it's not flat, it's at an angle, so that when they bite and they contact, they slide up and forward to keep the mandible up and forward, to keep the condyle under the disc and keep that part working as a complex. So the little guide planes, you see top left diagram, there's an incline there. So in the mouth, that thicker area provides that incline. So we bite and we slide up and forward, which gets us supported and placed in the condyle in the fossa region, condyle to fossa relationship. So it helps us. So we're looking at this going to this and then holding it there to be supportive. And then near the end of therapy, we'll gradually seat this back to be its best physiologic anatomic position. It's a little overcorrected here, but it has to be. It's a therapeutic position. Later in treatment, we'll go to the final finishing position. Okay, what things in the bite are related to dysfunction problems? What would the literature tell us? What do we know from working with these? So wearing of teeth, the attrition, shortening of the teeth, we get overclosure, we get joint compression, we get displacement of the condyle, altered loading on the attachment, stretching of the collateral ligaments, especially the lateral collateral ligament gets stretched out and then disc rotates and goes medial. So these things are really important to hold the vertical dimension of occlusion. Cross bites are functional shift and collision and functional misplacement of the mandible. Open bite skeletal are going to really fulcrum and kind of inversely torque the condyle disc assembly and its placement. More than 6 millimeters of overjet, the mandible has to reach forward and then function out of its natural proper position. When we have lots of missing teeth, which isn't so common anymore, fortunately, but some patients still present with that, we lose that posterior support and then all the changes that come with it. And if we have more than 4 millimeters of asymmetric slide, we get in trouble because the joint is functioning out of its normal relationship, and then the collateral support and other things have to modify, unfortunately. A simplest thing with muscle patients is an aqualizer. It's just a fluid-filled water bag that goes over the bite surface. They don't bite as hard. They can wear it day or night, slip it in and out no matter what the bite. So we use a lot of aqualizers, and many times on a younger patient or a patient early in a problem or a simple musculoskeletal problem, we might use that. There's a variety of splints we'll use, but all of these splints, I'm capable of me sectioning them down to become part of a splint so that we've got enough to be a reference area, but yet uncover the teeth we want to move so they're free and they can now be relocated. So there's sectional splints after maybe 3 months of preliminary therapy or 6 months if it's a disc type of case. It might take longer to work through all that there is, but there's different splints. And if we have disc problems, we need posterior support. Musculoskeletal, we can get by with upper or lower flat plane or cuspid guidance. They're all beneficial. And then when we get into orthodontic movement, we'll cut away part of the splint. So there's a partial splint. Top right is typical, where it's the posterior coverage. And then there's another group, I call them tripods, because we have contact in the front and contact on each side. So it's three-legged stool, the front and then each side. And so we could take a splint and cut out the middle section and keep the same reference position, but cut away all the side teeth except for their very back one. So they become tripods. And tripods are now enough to have the mandible target that position because they've learned it. The muscle memory is there, the resting length, the sarcomere uh, placement. They've learned what they're targeting from the proprioception. They learn that and they'll get by with less acrylic. So we'll start sectioning and cutting them down to make them partial splints. And this is enough so we can unlock the bite. We can start changing the bite and yet have the splint benefit. So these are tripods, upper one on top screen, lower one's just a dipod. So the front's got some contact, but the sides are all we have really. It could be a bipod or dipod, whatever term you want to use, but basically back support to keep that condyle relationship better. So there's chapters in the textbook describing how to do this, how to convert splints to sectional splints. But let's go a simple example. If a lady comes in from Montana, she's had lots of night guards for a lot of years, and now she got into a early closed lock, and she makes a trip over. We do repositioning therapy, and the typical thing that you're going to see as a therapist is the back teeth are apart. So now the back teeth can't reach. They used to, but they did only if the mandible could compress up and back. So she would go into her deep bite, she would compress up and back. It gets a little older, and the disc slips out and will not reduce. A closed lock, the pain with it, deviated opening, she makes a trip. So the typical thing I have to do is maintain the posture of the mandible and the disc condyle relationship and now get the back teeth to grow. What can the dentist do? They can crown all those teeth, make them taller. That's reasonable. It gets done. But she's got good natural teeth, wants to keep them. So it's my job to change that. So typically we'll widen the upper to get the transverse first, get ideal, bring the lower teeth up, and you'll see in the top right picture, there's some of the splint in the back. And in the splint, there's little yellow fibers. Those are Kevlar fibers. So when we're making these splints thin, we don't want them breaking and having to be replaced. So we add Kevlar in the orthotic so it holds up because I'm going to use that for 3, 4, maybe 6 months until I get to another splint or don't need a splint. She's got her back teeth reaching and she's finished. Well, that's simplified way of showing it. Let's go a little deeper now. When the bite's real deep and more complicated, maybe the front teeth have to lift. So we have to clear the front teeth. And at the same time, we have to bring the back teeth up so they reach. So we might have a open bite in the back, but it's much more significant. The front teeth has to be cleared for overbite and overjet, made to match, and the back teeth have to be elevated. Usually it's more the lower coming up than it is the upper coming down. So we have a deep curve of speed typically, front teeth taller, back teeth shorter. So we're gonna go in and section the splint and keep the middle part here. And then the back teeth, we're going to use elastics and wires to make the back teeth erupt and grow until they reach. So now they take over the functional positioning, and in between the teeth don't reach yet because the splint is there. And the front teeth are being aligned. So we're starting to get front teeth placement, back teeth elevation and placement. They're starting to reach. To help us do that, we'll use up and down elastics. And you'll see your patients come in, and typically the orthodontist just puts the elastic on the outside. Problem with that is the teeth come up, but they tip in because the elastic's only on one side of the teeth. So they're erupting, but they're leaning, tipping inward toward the tongue. And they have to stay wide and upright. So if the elastics are crisscross or they're on the outside inside, there's going to be a vertical trajectory and they're going to erupt vertically and come up into contact in a new vertical dimension that's better. So they erupt to the level that the splint was, and then the splint gets shortened up and eventually goes away because the back teeth take over that position. Let's take Mike. Mike commutes in from Catalina Island up here to the office. And a dentist there had referred to me for years and kept referring, had the patients commute. Well, Mike's sleep apnea, he's on CPAP, he's all of that, worn down teeth and all these things, a lot of attrition. So Mike's reports, I haven't slept most of my adult life. I can't eat and chew because my teeth are worn off. A lot of myofascial findings, lateral capsulitis. OSA was not completely diagnosed, so we helped that and the bruxism with it, GERD, and a lot of cardio problems. So that's some of the history. So his full splint went to a segmental splint, and often on these splints, I'll put a jack screw in. I don't use it when they're in the stabilization phase, the pain dysfunction phase, but it's already in the appliance. So later when I cut it down, I've got a device that can start widening the arches. So I don't want to change the teeth until I've got the somatognathic muscle and joint conditions stabilized, the craniocervical conditions stabilized. Then I start changing what needs to be changed in the mouth. So Mike's in the process. So his splint went from full to partial. You see on the top right, the premolars have composite on them. So during the day, he can function with just those. He can have the splint in at night. I'm opening space on the lower front because he was missing a tooth. So we always try to recreate the full arch if we can. He needs that to give him more teeth and wider arches and full support. So we open that space back up, and then lower right, he's restored. So again, in the process, I had that lower orthotic with a jack screw to widen it. It widens it, brackets around to take and put all the space in one spot so we can get one more incisor. And then it gets restored, all those teeth built up to the new vertical, the vertical that the splint gave us. One more example, and then we'll get into questions. So arches can be moved, and I want to use appliances that don't affect the tongue space much. I want to unlock the mandible, keep it forward. This lady's worn down, all the sleep issues and that. And she wants to know, can you get me off a sleep mask? One of her friends who had come in, we'd been able to do that, but it was a different treatment plan with surgery of the lower jaw. So anyway, I want her to see what we could do for her. So certainly stay on the CPAP for now, but I think I'm going to be able to get you to where you can be managed with an OAT, with an intraoral appliance, which we did, but only after sleep testing and getting to the end. So anyway, we're changing the vertical. The mandibles opened up, brought forward, teeth are moved. So this is her imaging, and again with the cone beam and the software, we can make these beautiful images and help communicate to the patient and to the colleagues what we're doing and why. And so the orthotic is made. Top right, you see I've cut away part of the orthotic so that I can put composite bonding on the teeth in those same spots. So I'm doing this to test. So during the day, leave the splint out, function on the turbos, and then at night, put your splint in because of the bruxism. Later on, I only had the very back of the splint, the dipod, 2 molar coverages to decompress and hold the vertical while I'm bringing her teeth together. Eventually, it gets opened up enough, and then we use computer programs to put smiles in so we can show them different tooth sizes and shapes. And it's basically it's like a test run, kind of trying on an outfit. So we might pick 3 or 4 smiles that match what they should be, and the shade and the shape. And certain shapes are more masculine, rounded edges and curves are feminine. So we show them the different smiles and then plan that and have the dentist take over and create that. And so we've got turbos on the whole time. So the dentist doesn't change the bite on me as we're doing the restorations. So we've got our imaging repeated. We've got our provisional, meaning kind of the temporaries on the teeth in composite. So we're holding it. We're taking imaging. We're looking at the smile line for aesthetics. We're measuring the length of teeth. It's called Shibashi length, but it's basically what should be showing at relaxed and repose versus full smile. And so we're planning all that, doing it in plastic, and then doing it in porcelain. So this is where it's managed. And the whole time I had a tripod in, so her bite wouldn't start collapsing or close down on me because she still bruxes. But now she bruxes on the plastic, but she bruxes less, but she still does because of the sleep problems. So with her, this is the appliance she's using. She's got the restoration. She looks great, very happy. She's got an oat appliance that she wears at night, and she wears this a few hours during the day because she still clenches. So she catches herself clenching, put the orthotic in so I can hold that relationship and just keep everything functionally happy. So that's how we managed her, but we did get her off the CPAP. But sleep testing was done with the CHAP appliance and to make sure that it was managing the problem. So I work with the pulmonologist. We'll cover more next time on this too, but in retention, all these patients need some orthotic. And we can't just make a kind of a floppy plastic retainer and put it in there and release them. We want to functionally support these patients because they're different. They're not like the orthodontic patient with pretty much normalized or at least optimized functional components. These patients need more support in retention. So we make retainers that can be adjusted well against the orthotic. And if it's appropriate, if we use a bonded wire behind the lower front teeth, we do not go 3 to 3. Almost always you're going to see from canine to canine a little wire, or maybe 2 to 2 a little wire. By including back to the first premolar, the posterior teeth function together, but the 6 front teeth they can have a wire, but they still can deepen. The bite can deepen with those teeth connected together with the wire. As soon as we include a premolar, they can't deepen because the premolar is already in functional contact. So the front teeth hold, the overbite holds. And so it's just knowing that means that the orthodontist designs his retainer with the, reaching back one more tooth and it'll be stable. And if we don't need that, that's fine. So the patient helps me decide that. And most of the time it's some orthotic and some opposing retainer. And the orthotic can be in either arch and the retainer can be the opposite arch. So the next category is TMJ intracapsular. And guess what? Jenny said we're doing that part B. That'll be next time. So those are complicated conditions. So we need another session for that. So thank you very much for
Wow.
this time.
Thank you so much, Duane. We definitely went a little over than what I thought, but this was just so
Oh, did
great.
I? Did I ever? Thank you for sticking with me.
I know everybody is just, I wish you were in Chicago. You're so creative with the approach on every case. Can you go back to this recent case that you just went over? I just have a few questions about that.
Sure.
This
This case
woman,
here?
yep, keep going, keep going. It's like her first picture right there. Go back. Right now, go. You're good there. Keep going. This is the case I want to discuss. This one. Can I see her picture? So this image right here of her teeth, when I see this, I think, okay, this woman has sleep problems. What I see a lot of posterior molar dental work. I know that that means a lot of bruxism during nighttime.
Yes.
The teeth, when you can see inside the tooth, what does that mean to you right here where it's like yellow? That's just sleep disordered?
The yellow is, we'll see a tooth is normally enamel on the
Yep,
exterior, and then dentin internally. When the
yep.
enamel wears through, the dentin starts to show. And the dentin is either yellowish, brownish, it's very dark. And so once we've lost the whole enamel coverage, the dentin is exposed. But if we took a normal tooth and cut away the enamel in one step, that'd be highly sensitive. None of us would tolerate that. However, when it happens over time, the
Yeah.
body inside the tooth is laying down additional layer of dentin. So the distance from the biting surface to internally where the nerve is, that actually is remodeling internally as the top is wearing away. So
Wow.
God and nature have created that to give us that protection so it doesn't become sensitive. So we look at these and wonder how could that patient not be sensitive? And often they are to cold because it's still less
Yeah.
protection, less insulation. But many times they say, I don't have any problem. I can eat anything I want. But
No,
if anything, it might be cold. Sometimes we'll use ice to test, but who wants to do that and hurt the
yeah.
patient? It's obvious what the problem is.
Keep going another slide again. There was an image that you had her, an appliance over braces even, I thought.
She was treated with aligners.
So the fact that you're adding, for example, that one, go back. So one,
More, okay.
yep, and the other way, I think. So this image that you have, this dipod that you said, that you wanted, nope, go back. The light blue image with the appliance that you have in the
Yeah, in
back.
the top center.
Yep, that goes on
Okay.
the upper or the lower.
That's can be either, but that's a lower.
But so you're saying that posterior tooth, you're okay with just putting all the load on that back tooth for patients, and you were saying maybe it was best for disc problems or just decompression? Can you
Well,
explain that?
in her case, it's good for any of those because she's overclosed. So I'm fighting to get the vertical reestablished open, which means altering the muscle length and the whole posture of the mandible. So it takes time to gradually change that in the full orthotic. And once we got that as a target or the reference position,
Yeah.
then we don't need as much of the acrylic splint to hold it there. They still target it. And there's a front too. My glove is covering the front. but the middle left side, you see another picture of this of a similar appliance, just different stage with her,
Yeah.
because I might make two or three to get through it. But the second image down on the left side, I'm holding that dipod
Yeah.
appliance or bipod.
Yeah.
And now you see I'm adding acrylic in the center. So I'm thickening it. So she's probably worn it down some, and I put a little drop of light cure
Yeah.
composite and I cure it and put it back in, but it's added to the thickness. But there's a front part too that hits. So she hits on the front and two back regions. So there's really three regions of support, not just the back. So it's really a tripod.
It's
There's
amazing how you try to grow the bike because she's lost vertical, but the technique of adding certain either you were calling them what do they call the bumpers? The
we call them turbos.
turbos, the
Yeah,
turbos. So you can put that directly on an appliance or on,
the teeth. Yeah.
and that's the turbos are meant to guide and to guide
And hold the
the
vertical, the
mandible,
height. Like
the
when we go
height.
back to Mike, the case before that, see how Mike, I mean, early on, top right, see, I've
Yep,
got both premolars
yep.
already covered with a composite right early in the treatment. I mean, he doesn't even have full braces on. I'm just starting in the front lower teeth there. And
So
then,
the point is just to hit when he bites down, he hits only there.
yeah, but it's interesting. Two things. It's enough to hold the position. But the second thing is when we look at bite forces and
Yeah.
different EMG studies that have been done, but they don't bite as hard because it's not a hard enamel type surface. So that we're so smart with the proprioception, the neural feedback, that we don't bite with full muscle load. We basically bite, and we've been contacting on this, but we don't bite with our full 100% masticatory load that we had put on if it was tooth to tooth contact. It's interesting when it's tooth to plastic. We don't bite the same.
Okay, and then the go back one slide.
Oh,
The
back from Mike.
no, go. I liked him. Go back one with it. You could see an appliance on top of braces for him.
Oh, down lower left.
Yeah, lower left, but there was a one more picture that was I was like, whoa, I've never seen an appliance on top of when you have braces, because I've always thought, things are not even always, and how do you approach that as an orthodontist? I only
Well,
see orthodontists like working with the teeth and the braces exteriorly, laterally on the tooth, never like working on the occlusion on top while they're in braces.
I think that's hugely important. That's really important to be able to do this because you've gone through the stabilization phase, all the therapy you've provided to help them and whoever else is on the team. When we've gotten to that point where they're stable, comfortable, and all that stuff. A lot of orthodontists will say, well, I'm going to straighten your teeth, throw the splint away. I got to have your teeth so I can move them and have them free. Our philosophy is completely different. It's like we've done all this work to get you comfortable, stable. We're not giving that thing up. I've had patients kind of do this thing where they cover it up and say, no, you're not taking that away from me. That's helped me. And I say, I agree. We're going to
So I
modify
had
it,
I
but we're
I
not
had
giving
a
away our
case. I love what you're doing. Like I had a case that was an orthognathic case after we had worked with her with an appliance to hold her in vertical, and the orthodontist and the surgeon were like, we got to take that out and work on the teeth. And she went into a complete neurological disaster where she
Sure.
was clenching, biting her teeth, biting her tongue and lost all that vertical. And I'm
Yeah.
like, couldn't we just keep something in between the teeth to help her maintain that height for her nervous system, for her joints? And they just wouldn't do it. And
And I
she,
actually, in that circumstance, I'll use the term reference position, which I really learned from Slavacek, who's from Austria, but he's the one that invented the articulators we use for these kind of things. But
yeah.
you start calling it a reference position or a therapeutic position. And it's that position of comfort stability. So we're not calling it your centric bite or your habitual bite or centric relation, none of that. This is your therapeutic reference position. We've worked together hard to get you that
Oh,
well. Let's maintain that while we modify the occlusal arrangement. So yeah, I'm not giving that up and they're not giving it up. Why would I
I just,
invite that to come back?
she's in a place where she can't even talk now. She was a newscaster and now she can't talk.
Oh,
It's
oh
really
my
bad.
goodness.
Well, I might have to collaborate with you on her case at some
Sure.
point, but
Yeah, that's
um,
unfortunate.
It
And
is.
their places
You're
are so small and simple. I mean, they can speak, they can talk well. I mean, we have patients that are, whether it's an instructor or somebody who lectures, does, seminars and things. But that's another reason why I like the composites today, because I can do so much with composites to hold them during the day and they can do life. And at nighttime, add the orthotic back in to have more, support and stability.
Yeah, it's just when you lose that vertical, you lose some airway space too. And she's
Yeah.
just clenched. She cannot talk. She has to have her
Yeah.
teeth together. Anyhow,
Yeah, and then
I
the whole
wanted
muscle
to,
resting length changes, which you guys know better than us. But your sarcomere length, all your resting length, all that stuff changes, and we've
yeah,
got to reverse that.
I know. I'm so excited for the next one. I feel like we need to, there's one question. If anyone has any questions, please put it in the chat right now. The one question that someone came through was very curious about your evaluation and your speech. You were saying you do videos, and what is the point of looking at the speech, and what are you asking them to do?
Well, if there are articulation problems, whether it's just because of the arrangement of teeth or lack of anterior closure and plosives, and what I'm trying to do is have them speak without thinking about speaking. So there's two tricks to that. One is I have them count backwards. And typically I'll have them count in the 60s or 70s. So they have to, do the S or THs, but I'll have them, we'll videotape while we're doing that to see if there is any compensation or the tongue is in between, things like that. It shows up right away. And the second trick is, or not trick, but the testing we'll do is church, house, zebra, his house, church, judge, zebra, the 5 words. And we have it typed up big letters. And we just say, just read these words. They read them while we're videotaping. And we'll usually video from underneath the front teeth so we can see. And of course, we see the perioral musculature and all the reaction there. And then we'll do a sip of water and have them hold it and then swallow. And we'll video that too. So those are some of the preliminary tongue functional things we'll do in the eval and video those.
Duane, where do you teach? Where can other orthodontists or even dentists learn from you? Like, what are you teaching in any capacity?
You
Anyhow,
know, I teach like I've been on staff at Loma Linda Ortho Department 43 years now, and so on. But those are obviously closed to faculty and the
yeah,
residents.
but like,
But it
does
would be meetings, but
your approach is not the norm and average approach, Dr. Duane. You
yeah,
know that. You're not,
well,
I don't have that here in Chicago.
I did hands-on courses for specialists. I did them for about 30 years, where 10 doctors would come for 3 days. And we did level one, level two. And level two was really complex cases where we're doing total joint replacements, double jaw surgery, and all the big stuff, and treating the myofascial, treating the joint. So that was day 4, 5, 6. But the 1 through 3 is the typical stuff I'm showing here, and we'll show next time. We did it with hands-on, and 10 docs came 4 times a year, 4 groups a year. So that was 40 a year that got trained up. And I still see them at meetings once in a while, some of the ones that are still out there doing it, or I'll get a text or a message once in a while. But there aren't many of those still in practice. And I'm not doing the hands-on for the past, 15 years.
I
So
know.
I,
Where can
I
people
just,
learn this stuff though, Dr. Duane?
yeah,
Where?
I avoid. And I've got textbook. Don't get the textbook because you're not going to read it and do it. You have to be shown, and we still got the manuals and all that stuff. I wouldn't tell anybody to get
Is
these.
there a list of orthodontists that you've trained that we could, is there a list of people that know
Ooh.
this?
I lists, I honestly, they're actually paper lists that are in storage because all the files have been relocated off
Yeah,
premise.
yeah.
And if I had digital, it'd be nothing to it. I'd send it. But honest to God, that's been at least 15 years since I did them.
This is too good, is what I'm
Thank
saying,
you.
to just
Thank you.
have it go away. Like
You know,
Dr. Duane.
Steve Olmos was one of the ones that's so vocal about the book and the techniques. And I appreciate that Steve talked it up. But I from people that say, where can I get the book? Is it still in print? And the both been sold out. There were 10,000 that got printed and they went wherever they went. But
This is
this stuff you have
amazing.
to be shown. You have to
This
sit
is
with somebody.
amazing. what you showed us today at the end, I just not ever seen anything like it. So I'm just fortunate to show
Thank
you
you.
and have this now filmed. So thank you.
Well,
Uh,
your therapist can take the concepts to their doctors and bring them up. And they aren't complicated, just a little thinking.
yes, I just wish that there was a place for dentists to learn this. I do.
And
I'm
I
going to
do
go
too.
back to,
Yeah, I do
so
too. I love it.
here, go ahead and stop share for a moment. And I
Well,
don't see
I'm
any
gonna,
other questions. Does anyone have anything else?
here's where we're going next time.
Okay.
It's complicated real fast, but
Oh my goodness. Appreciate this, Duane. Thank you so
yeah.
much. Thank
And
you
your
so much.
colleagues can share this with their orthodontists and others that are part of their team locally. And
I
that'd be a way
will.
to share the info. Yeah.
And maybe it would just spice up some because they're so focused in the way that they do things. They're not always looking to do something different, unfortunately.
Thanks for your encouragement, Jenny.
Yes, yes. We will be doing the next one next time in January. And thank you so much for your listening. I appreciate everybody's wanting to learn more about the craniofacial region and the airway.
Okay.
And thank you very much. Thank you for listening to the Breathing Lab with Dr. Jenny.